with that, again, can everyone see my screen okay? Awesome. Thank you, Carrie. So today we're going to talk a little bit about home health services. We're going to talk about things that are probably good or what you're most likely to see associated with home health. We're going to talk a little bit about patient eligibility. We're going to talk about homebound status, kind of what that means to me, and as I'm thinking about ensuring that we're ordering appropriate home health services, what that means or how I'd like that to be communicated to your providers. Some tools that we're going to send out. I'll probably send them out on Friday because we're trying to get a new data load completed this week. So when that's completed, you'll have a little bit of extra information. And then some tips for being successful. So to kind of jump right in, the reason why we're talking about home health services is we want to make sure that any patient that's receiving home health services qualifies and is benefiting from the service. Just the same way we talk about durable medical equipment, about pharmaceuticals, we want to make sure that those that get it get exactly what they need, and those that are receiving it are getting it really well. That's kind of a quote, or I probably didn't do the best adaptation of the quote from one of my providers that I'd worked with in an ACO that had really high home health utilization. And his real takeaway was, Adam, you're not telling me to not provide services. You just want to make sure that those that are getting it are qualifying for it, and those that are getting it really well and are really benefiting from it. So the idea of thinking about home health is going to be really important because there's just a lot of inconsistencies around the use of home health. Some people will use home health because it's the only way to get physical therapy. Some people will use home health because it's the right thing to do. Maybe it's that extra intervention for a patient, or we're trying to figure out how can we discharge a patient from the hospital one day sooner? How can we get a patient home one day sooner? How can we make sure that our patients are thriving? So because home health at times can be used a little bit inconsistently, we want to make sure that we're evaluating it, we're looking into it, because at least once a month you're going to hear about a story of potential abuse related with home health. And when we think about abuse with home health, I don't want it to come across as like physical abuse. We're not saying anyone is harming the patient. We're saying abuse more in terms of like physical abuse, or taking advantage potentially of a system, maybe even because we don't know the rules, or because the rules are being interpreted differently than I'm going to promote them today. And again, I'm Adam, I'm from Imperium, I'm not from Medicare. I'm just trying to use my experiences that I have based on working with other ACOs to hopefully help out as much as possible. So when I think about home health services, there are a couple things that we normally think about that are qualified or that should be paid for. And then there are some things that really shouldn't be paid for as from a home health perspective. So the things that are in the gray box, I will look at and say, as long as the patient needs it, absolutely let's make sure that we're trying to get home health services for it. As long as the patient qualifies and the patient is benefiting from the service, let's make sure that they're getting those things on the left. That physical therapy, that OT, maybe some of those additional education things. One of the things that I love the most is when you start to think about how can we bring in a social worker to connect with any community resources that might be available. And these are the things that Medicare says they want to pay for. So when you're ordering home health, or when one of your providers is ordering home health, it should be for the things that are in the gray box on the left. Now that's not a completely exhaustive list, but that's a pretty darn close list. The things that are in the pink box on the right, so think about pink as maybe closer to red, are the things that we really shouldn't be promoting. Now prescriptions are oftentimes something that's covered either through like a Part D or even sometimes covered through Part B. That's not really something that should be covered through home health services in that Part A. We would not expect our home health agencies to be there to provide transportation or rides. There is instances where sometimes you will have non-emergent transportation that can be paid for by Medicare, and that's okay. But I wouldn't look to a home health agency as being our transportation source. There's some things that are covered under like an end-stage renal disease program, and those are reimbursed separately. That really shouldn't be covered or paid for as part of home health. That's not to say that a patient couldn't be receiving non-emergent transportation paid for by Medicare, but that's going to be billed through a different kind of program and policy. And that's not to say that a patient couldn't be receiving some extra ESRD services. Now the one thing that always stands out to me, and sometimes you'll see it covered by a Medicaid or even a grant service, is housekeeping services. This is something that sometimes you will have a CNA come to a patient's home, and what the patient really needs is just housekeeping or housework. And that's different than having a CNA come to a patient's home to provide maybe walking support or kind of some extra, fall precaution or even medical interventions. So housekeeping services is that the person that comes to your house maybe cooks, cleans, some of those things. That's not what home health is intended for. And again, today is not meant to be good or bad with any of your local providers as much as it's just, let's think about how do we make sure that what we're ordering is what our patients are qualifying for, and we're positioning those ordering providers to be as successful as possible. So a challenging part about home health is that when we're trying to think about home health services, and we're in a clinic, we're seeing 20 to 40 patients every day, if not even more if you're some of the larger groups. I'm sure for Debbie and Southwest Internal Medicine, they're seeing a lot of patients every day. Now, a home health cert can be kind of funky because it's not one patient for one 15-minute visit. It's a 60-day certification, and essentially the agency is in charge of providing almost all care for the patient in their home for 60 days. Now, when I say providing pretty much all care, and if we think back to that last screen with that gray box, there's a lot of different things that can be provided to the patient. Everything from that CNA intervention, physical therapy, OT, maybe we're starting to get into almost like intervention or infusions. That can be a pretty wide variety of services that's provided. And because there's such a wide variety of services that's provided, there's a huge variation in terms of the cost per certification. So again, a home health certification is for 60 days of care most of the time. Sometimes you'll get something called a low utilization service, but most of the time it's a 60-day certification or a 60-day period of care that the cost is going to range from about $1,500 for that 2 months of care to about $4,000. So it breaks down to about $7,500 a month to about $2,000 per month. I haven't seen too many certs that are more than $4,000. I will tell you the things that cause care to be a little bit higher, a little bit more on the $4,000 end, or is the physical therapy services, maybe OT services. The more of those kind of support or therapy services that a patient receives, the more expensive that certification will become. So that's especially important as I'm thinking about, well, we want to sign the patient up for home health because it's easier for them to get physical therapy, even though the patient might be capable of driving themselves to an outpatient physical therapy center. So to qualify for home health, patient must be homebound, and that's a harder concept to understand, and we're going to get into that a little bit more on the next slide. But the first thing is patient must be confined to their home. Now, I'm not a Medicare employee. I did my best to try and interpret Medicare rules or work with the local Medicare claims adjudicators as well as some home health companies to think about, okay, how do we make sense of homebound status? When a patient's receiving home health services, they must need some level of that skilled service. Now that goes back to that pink box that we had on the first page where we think about skilled, and skilled means probably something more sophisticated than housekeeping, cooking, and cleaning. And the patient must be under care of a physician, and they must have that care plan reviewed on a pretty regular basis by a physician or by a provider. And they must have had a face-to-face visit by either a physician or a kind of non-physician practitioner, so your PAs, your NPs, before the start of the care. This is going to be important to make sure that we have a provider that saw the patient, is making sure that the patient, when we visually laid eyes on them, that they really need it. Now this could be an instance of maybe a patient was in the hospital and had that certification started before the patient was even discharged, or as the patient was being discharged, the home health was being ordered. That's okay. We just need to make sure that there was a face-to-face encounter. Any questions so far? One of the people that joined a little bit later, there is a little bit of background noise going on. I don't want to point fingers, but we do have a pretty small group. So with just the 5 of us on the phone, if you're not talking today, could you please mute yourself? Well, I don't know who might be given permission, but if possible, could you mute yourself? Okay, thank you everybody, and I apologize for the meeting situation. I know it's hard. So I said the thing that we were going to follow back up with was homebound status. So with homebound status, it's important to remember that the patient is essentially kind of confined to their home. Now, to be considered homebound, a patient must meet both condition or criteria 1 as well as criteria 2. And it's, again, a little bit more challenging to think about homebound status than some of the other things. We order labs all the time, and we want to make sure that we have a qualifying condition. Homebound status can be one of those fringing on potentially inappropriate things that we always want to make sure that we're considering when we're ordering home health for a patient. Because we want to make sure that if a patient can go out and drive themselves to drive themselves to the mall to go shopping, or they can drive themselves to church, that they're probably able to drive themselves to an outpatient physical therapy service or drive themselves to an outpatient wound center. So the patient must, and I'm going to kind of read off the screen, because of some illness or injury, need the support of crutches, canes, wheelchairs, or maybe an extra person to leave their house. So that doesn't necessarily mean that they have to be in a wheelchair, but they need a little bit of extra support to leave their house, or having almost like a condition where leaving your house is almost contraindicated. Leaving your house could cause you to fall. Leaving your house could cause you to get sick right away, or you potentially don't want to be exposed to things that are out in the environment. So the patient must first kind of qualify as being homebound, which means it's very difficult for them to leave their home. And I would say this is one of the things that, as I'm having a patient come into the clinic, that if they drove themselves, and I would kind of joke that if you have a woman that has freshly manicured nails, or you can tell that she just had her hair done, I would be concerned that she might be out and about maybe more than somebody normally would be for qualifying for homebound status, especially if she's the one that drove herself. And then the second criteria, so not only do they have to be homebound, but they also have to meet a criteria that says that it's kind of especially taxing. So there's a normal inability to leave their home, and then leaving their home must require a considerable and taxing effort. So I would almost interpret this as when you go to church on Sunday, you might be pretty tired until about Tuesday or Wednesday. Like, that was a big deal. So when grandma's going to church, she's kind of pooped until about Tuesday or Wednesday. Now that's, again, my interpretation, and we have a link that's down below of how to get to the Medicare Learning Network kind of criteria on what homebound status is. The most important thing is it's difficult for a patient to leave their home, and then kind of once they leave their home, it's kind of tiring. So once we've identified, yes, this is a patient that qualifies for home health services because they are truly homebound, we need to start to think about what's in that home health care plan. So the home health agency is essentially acting as an extension of the providers, and that home health care plan is something that is required, is almost like an order that the patients are following. So with that, the things that can be included in there are pretty vast, but there's a few that I always try and pay attention to. So one of the things I would always look for is rehab potential. So as I mentioned on that cost slide where we talked about $1,500 to $4,000, the more rehab services that are provided to a patient, the more expensive that certification becomes. What activities are permitted? And I'd always be looking to see, are those activities changing, or do they seem reasonable? What is the prognosis? Does it seem like our patients are getting better? Because if it seems like our patients have really plateaued, why are we not changing the care plan? Or is the patient still really benefiting from the service? And then I always will sometimes take a peek at the frequency of the visits to be made. I like to look at this on the home health care plan as opposed to looking through claims, because that's something that's kind of right in front of you, and it'll stick out of, you know what, this seems like an appropriate number of visits, or this is similar to what I'm seeing from other providers or other home health agencies. The things that are on the right in that gray box, they're important, but I don't look at those quite as much. I would say that those are maybe less likely to be embellished or kind of rounded up. So when I'm, again, a home health cert is an extension or a delivery of care that goes beyond the clinic into the patient's home. So because we as a clinic are often ordering this, or the providers ordering this, it's important that we have a process in place that positions those providers to be as successful as possible. I oftentimes view it as they are so busy as it is that if we try and add one more thing to their plate, we're going to be almost overwhelming them. So I like to figure out how can we designate a team member, and it could be a registration team member, it could be someone clinical, to have them do a little bit of extra support to the providers in reviewing those research. Because again, we want to make sure that anything that was ordered was appropriate, because that would be the same as ordering a lab test on a patient that didn't need it or didn't qualify for it. It would be the same as ordering a piece of durable medical equipment, or ordering a prescription on a patient that doesn't need it. Because although it may not physically harm the patient, if it's providing a service that didn't qualify for, or that somebody's paying for, that's kind of like if you got charged a bill for something that you really didn't need to have done. I'm looking out at my lawn and it clearly does not need to be cut, but if I had somebody that said they'd be willing to cut my lawn for $20, I'd tell them to go take a hike. I would always consider having a team member kind of pre-screen or look at those 485s as they come in. They're a big, thick booklet, and to be honest, it's pretty easy for a provider to let them sit on their desk until a Friday afternoon, and as they're looking at the golf course, sign a whole bunch of them so that they can get out the door. Or to have that home health agency that is always really sweet about bringing in cookies, drop off a stack of these and make sure that the registration team member who maybe received those cookies, that they always push them in front of the provider first. Because, well, they're going to come back in an hour and I got to get them signed. I would take the time to review those, and I'm not saying doing an exhaustive review, but take advantage of, if we're being paid for care plan oversight and we're getting $40 for that, let's make sure that we have somebody dig into this a little bit and review those to make sure that we're getting paid, or that we're kind of earning that care plan oversight dollar. I would always say review the research or those requests on a pretty regular basis. I always say at the very least do it weekly, if not more often, because if you kind of allow for those delays in care, or there's a potential for care to be provided that wasn't appropriate, or kind of miscommunication between the care team and the home health agency. So with home health certs, we should be expecting the home health agency to be dropping off a recert request between about days 50 and day 56. If we start getting recert requests that come out on day 60, day 70, day 80, day 90, I've even seen them come out on day 100. We don't necessarily need to sign those. Now that's a situation where you might have a home health company or home health agency that's providing care to a patient, but it wasn't really signed off on. That's almost like if a pharmacist was going to refill a prescription, but they didn't have a prescription. They were saying, well, you know what, I think the doctor would refill your albumin. Well, if we don't have an order, we really shouldn't be continuing to provide the service. This is a bigger deal of that kind of care being provided with agencies that are not as good with their paperwork. And I've seen it more often with small agencies being kind of offenders with this than big agencies. Big agencies are typically better about, or more sophisticated groups, about sending their bills out on time, or sending those research out on time. The smaller agencies are more likely to kind of let things build up a little bit, from my experience. And that's not to criticize any or all small agencies, because the important thing is making sure that if we're signing off on an order, that we're signing off on it before that it was provided to the patient, and that we agree with it. So reviewing those recertifications as they come in, and that's why it's important to make sure that we're getting them early, is so important to make sure that the patients are receiving the care that they qualify for and that they're really going to benefit from. So if we start ordering services that the patient doesn't qualify for, if Medicare or somebody came in and took a little bit of a closer look, it could be viewed as abuse. Now again, that's not to say physically harming, that's more in terms of abuse of kind of the system. That you're providing a service that really wasn't qualified for, or that shouldn't have been paid for. Now we're going to send these couple tools out probably Friday afternoon. So Friday afternoon, Friday evening, we're going to send some tools out for success. The reason for the delay is we did a data load for our Q1 data, the information that came out, or the attribution file that just came out from CMS. And we want to make sure that we have the best information possible, so we're going to take a little bit more time this week to make sure that we're massaging that, have the right list for you guys, and we're going to send out a list to all of you of the patients that we believe have received home health services this week. With those, we're also going to send out a couple tools for success. So we have two screening tools that we use. The one on the left is one that we developed for a provider that had an extensive number of patients on home health, but it seemed like there was some inconsistencies in terms of what was actually provided to the patient. Things like the patient might recall they came to my home and we had coffee, but the research request indicated the physical therapist went to the patient's home and we did lower leg strengthening or leg strengthening exercises for 45 minutes. Well, that's a big difference, because what the patient is perceiving is happening is essentially what's most important. Because if the patient believes that no value was added, then maybe we need to think about a care alternative for the patient. The form that's on the right is one that was developed as a kind of tool or extra support for as we're reviewing those 485 requests. And this might be something that you would even want to start to think about having the home health agency start to fill those out on your behalf as the research are coming in. I know as we start to work more with our agencies, tighten those relationships, they're going to start to come up with ways to make it easier for us, as opposed to just easier for them. So the more we can kind of help them to help us, the more successful everyone will be. So we will send both of these tools out a little bit later this week, along with the video and along with the list of your patients that are on home health services. So when we're reviewing those forms, there's a couple things that I always like to think about as kind of potential red flags. And we touched on those just a little bit ago when we mentioned the kind of 12 things that you most commonly see on the research and the things that I would normally pay attention to. I would always look for changes in diagnoses. I would always look for lack of improvement in any way, as well as any services that seem to be escalating without documentation. Like, why did we suddenly start receiving more wound services than before? Why did we suddenly go up in our physical therapy? I would always look for changes in documentation. And to me, what this means is as home health agencies have started to adopt templates, started to adopt EMRs, things have become pretty standardized in how we get the information. If it looks like the information is the same, exactly the same, almost verbatim, cert over cert over cert, I wonder not only how much time are they investing in developing the care plan, but are they updating and providing accurate information? Because if we're not getting good updates as the care team, we can't really help to drive what the care plan should look for, or what it should look like. We have an agency that we identified this with. Boy, it sure seems like your stuff looks the same month over month over month. And when we pointed that out to them, we then started to notice that they almost alternated between an A template and a B template. So in January was template A, or documentation A. In March was documentation B. In May was documentation A. In July was documentation B. And it took a little while to catch on to that, but that's something that I would always try and make sure that you're looking at is as you're getting those research requests that come into you, pay attention to the verbiage. Make sure that that the information looks as correct and as accurate as possible. I would always look for any of those delays in research requests. I mentioned possibly getting things on day 70, 80, 90. Those are real red flags for me, because that indicates to me that if you're not willing to send the research request, how many other things are you slow about getting back to me? How many other things are you slow about making sure that I know about? And that could be everything from a high blood pressure measurement to making sure that you're reaching out to me if the patient suddenly takes even a slight turn for the worse before we automatically take the patient to the hospital, automatically take the patient to the ER. If we're not communicating the research, I wonder about what other things are we not communicating well. I would always make sure that we're monitoring those dates of service. So on that 485 screening tool, we have date of last face-to-face visit. And when we start having patients that are on for 3 certs, 4 certs, 5 certs, 6 certs, it becomes less of an acute intervention, or kind of a semi-acute intervention, and more of just a really almost long-term service. We want to make sure that if our patients are on for very long periods of time, that we're paying attention to, are you really benefiting? Are there other alternatives? Are there other care options that are available to provide to the patient that might be more appropriate? And are you still benefiting from the service? So those are a couple red flags or things that I always try and pay attention to on a recert form. So when I'm thinking about who I want to partner with, the things that I would always look to identify are really good communication. Communication can trump a lot of things. I would say communication, in my mind, can be more important than awards and things like that. But timely communication can be one of the most important things back to you as an agency. We also want to make sure that if your patients, as I just mentioned in that earlier example, they go to the ER, if they're going to be admitted to the hospital, that we know about it ahead of time. That at the very least they're calling us as they're driving to the hospital, because we want to make sure that we didn't find out about a discharge when the discharge is occurring. I always like to make sure that if we have an agency that's starting to make recommendations back to us of when a patient should be discharged, that's a good partner for us, as opposed to one that just kind of always says, you know what, this is a recert, and forces us to dig through it on our own. I always like to see, what are our patients improving? Or if our patients are not improving, are they making changes to the care plan on their own to maybe help improve the patient's outcomes? And can the patient on their own identify services that the provider is or that the agency is providing for them? Now that seems silly, but we always want to make sure that the experience or the patient's perception of the care is the same as what was on the care plan, and the patient understands the benefits of the services. Because if the patient is receiving the service that they don't necessarily see benefit in, we may need to figure out, is there a re-education with the patient that needs to occur of, well, you should be getting physical therapy, this is what your physical therapy probably looks like, and this is the outcome we're hoping to get from that, as a reminder to the patient to make sure that they are benefiting from the service as much as they should, but also understanding the importance of the service that's attempting to be provided to them. So when I'm thinking about, okay, we maybe identified a patient, I guess I'll pause for a moment. Any questions so far? Okay. And if you have any questions, thank you, Ms. Carey. If you have any patients that you're thinking about potentially removing from home health services, one of the things that I always recommend to you is speak with the patient before removing them. It's an opportunity for us to tell the narrative, or kind of us direct the narrative to the patient, and to make sure that the patient's needs are being met as much as possible. This is important because I've had some experiences of, if the provider doesn't reach out to the patient and say, you know what, we're going to remove you from home health services, but it's because you're doing so good, kind of coach them up a little bit and really tell the patient how much they've improved from the services and how they're going to be able to function independently and just really thrive. So if we don't have that opportunity to direct the narrative from us, the narrative can come from the home health agency. And I say narrative as though it's a story, but it can be a story to how it's told. And I have had unfortunate experiences of the story or the narrative being directed as, your doctor doesn't think you need this anymore. That means I'm not going to be able to come by here anymore to help you. I think you're benefiting. I think you're really getting a lot out of this. I'm not trying to pick on a home health agency, but I've seen that happen multiple times. So the ability to bring the patient back in, or even have a phone call with the patient to say, you know what, we think you're doing really well. We're going to actually maybe enroll you in chronic care management instead of home health services, because that's maybe a better way for us as a practice to get good information, and it can be that same kind of interaction, that a medical interaction that a patient needs, but this might be even a better fit for the patient. I always recommend that if you work with an agency that provides medical social work services, to consider ordering that for a patient. And they may have connections or resources that are available within town that can also help to meet the patient's needs. I would document any discharge instructions, same way that I mentioned that sometimes we get recert requests on day 80, 90, that if we're not documenting those discharge orders, there's the potential that the patient may be receiving the care or continue to receive the care because the agency doesn't fully acknowledge the discharge. Oh, yeah, I guess we didn't get that. I bring it up not to be facetious, but because I've seen this happen with multiple agencies in one particular ACO. I always want to make sure that I'm monitoring patients that did get taken off of home health services to make sure that no one else picked them up. For that example of, I think you still benefit, we can find you a different doctor that's willing to sign for these. Sometimes with a home health agency they have medical directors that they pay sizable stipends for administrative duties. And one of those administrative duties may involve things like signing for patients to make sure that they're able to continue to receive services. That's a real red flag for me, and I would always make sure that I'm monitoring that paying attention to if we took a patient off of home health, that we want to call the patient, check in on them, see how they're doing, and that goes back to following up with the patients regularly to make sure that they're thriving at home. We may take a patient off of home health services and it turns out that they're really benefiting from it more than we first realized. We better get that patient back on home health as soon as possible because we want to make sure that they're getting exactly what they need. And then as I'm thinking about how do we really sustain this, we want to track those restarts. We want to make sure that we're contacting the patients that are receiving home health services, even if we're not necessarily thinking about taking them off, just to check in on them. We may even want to think about enrolling some of those patients in chronic care management to provide a little bit of extra support. We're going to send those screening tools out a little bit later this week to make sure that you have the information you need. And then I would always recommend, to build off of some of our earlier discussions, doing TCM visits as often as possible. Because on day 1 or day 0, when the patient's getting ready to leave the hospital, it might be one of those, we're not sure if you're going to make it, we think you're going to need a little more extra support. Home health may go out, start with the patient, and actually the patient does much better than we first thought. Maybe the patient has more support resources through family or friends than we first thought. So maybe they don't need home health as much as we first thought they would. And that TCM visit of that 7 or 14 day, bringing the patient into the clinic, just checking to make sure that they're doing okay, that they're really thriving following the discharge, that can be an opportunity to even pull a patient off. So rather than getting a 2-month or I say if you get them off a little sooner, it's almost like preventing the second certification, especially if the patient doesn't need it. So if we're able to have that intervention and possibly pull the patient off a little bit sooner, then we can start to think about how do we make sure that we are telling the patient, you're doing so well, we're going to get you signed up for, you're going to do a couple visits, and those couple visits are reimbursed at more like $150 a day, as opposed to Is that a question for me or a background discussion? Oh, okay. So that was it for what I had prepared today. Again, home health can be awesome. Home health is one of those kind of treasures that if it's done right, it's incredible. Home health also has the potential for being provided a little bit longer than the patient needs it, or is really benefiting from it. So I'll pause now. Any questions from the group? Carrie, I know you've been probably the most active through the chat. Any questions that you have for me?